Mhm. Thank you. I was about to ask him next when that was going to happen. So everybody definitely keep Jeff in your prayers next week. Anybody else to add to the prayer list? All right, no, Greg?
Okay, we sold a lot of raffle tickets. Before we do that, I want to ask Larry Mullins to introduce his two guests. I have with me Susan Scruggs, she's our marketing director, and Bill Lindsay, he's our chief executive officer.
Welcome.
Chief prospective members, Robert Johnson is here.
Mhm.
Thank you very much for coming. And Mark Taylor's back. Mark's back. Thanks for coming again.
All right.
Okay. We're going to have our guest speaker draw a ticket. Draw it in to see if you would. Okay, the winning ticket is 542. 542. Oh, there we go. For the Queen of Hearts. I'm going to find it. Good effort. 4 hearts, you got the right suit. All right, thank you. Thank you, sir. Thank you.
All right. Well, if we don't have any other announcements, Larry, you want to come up and introduce our guest?
Good afternoon. Today I want to introduce Dr. Ryan Schnetzer. He's a board certified and fellowship trained orthopedic spine surgeon. He completed his degree graduating cum laude while playing football for 2 SEC championships teams at the University of Georgia. Thank you. While at the University of Georgia, Dr. Schnetzer received the SEC Male Scholar Athlete Award, the Coach's Senior Leadership Award, and they achieved the SEC Academic Honor Roll for 3 years running. His special interests include treating mechanical and neurological disorders of the spine, disc displacement, spine deformity, and instabilities. He's certified in the latest minimally invasive robotic assisted techniques for nerve decompression, fusion, and these techniques provide shorter stays in the hospital. There's less recovery time. There's a lot less blood loss. Basically, you have a lot less collateral damage. So it's better for you. And it's hypersensitive as far as hyper accurate with the hardware placement. It takes a lot of that, the manual, when you leave it human error, it takes a lot of the human error out when you're dealing with the robotics. So anyway, Dr. Schnetzer, you will take over.
Thank you.
All right. Well, I want to first thank y'all for having me here today. Just going to kind of give a little general talk, go over some kind of common orthopedic issues that we see in clinic. And then I'll kind of go back into a little bit of my specialty in spine. Just a little overview. Again, first we'll start talking about arthritis, and then we'll kind of roll that into some discussion on osteoporosis, and then more into my specialty with back pain and some just a short review of some of the surgical procedures that we have available for treating back and leg pain. Let's start with arthritis. Arthritis, the word itself comes from 2 Greek words, arthro meaning joint and itis meaning inflammation. It's basically to mean joint inflammation. This can be referred to anything, any more diseases or a multitude of etiologies that can cause problems with joints and connective tissues that lead to pain, stiffness, redness, swelling, or difficulties moving a joint. Arthritis is not just a disease of the elderly. This can affect anybody in our population. In our young adolescents, you can have juvenile rheumatoid arthritis, and our middle adolescents, it can also affect them with lupus. Athletes through degenerative changes from injuries, and then our older population with the just standard degenerative arthritis. If you look at arthritis in whole, roughly 24% of all adults suffer from arthritis. Nearly 8 out of 10 Americans either suffer from arthritis or know someone who does. So what does it affect? Basically, arthritis affects all aspects of life. It lowers your quality of life by decreasing movement, your ability to be independent, which can affect your self-image and your self-esteem and your family life. Arthritis also affects business. It's the most frequent cause of work disabilities and leads to roughly, what I think 53 million, is it blocked there? There it is. Accounts for roughly 53 million days lost of work per year. If you look at what arthritis can affect, it mostly affects the major joints in the body, the shoulders, spine, elbows, hip, hands, knees, and the foot. This is just a list of some of the most common arthritides. This is not an inclusive list. You'll probably recognize most of these, but some of them you may not. But the most common arthritis that we'll see and then that will be affected of most people will be osteoarthritis. Osteoarthritis, again, like I said, is the most common. It's also called degenerative joint disease. It's kind of a misnomer. It's not truly a disease, as in something that's contagious. It's really just age-related findings that we see. Usually begins after age 45, and roughly 1 in every 3 individuals over the age of 60 will have some symptoms from osteoarthritis. This is basically caused by the breakdown of the cartilage in the joints. This can lead to bones rubbing together. When you hear people say a bone-on-bone arthritis in their knees or their hips, when this happens, the joints can lose their shape and their alignment. The ends of the bones thicken in response to the arthritis, trying to limit the motion. Pieces of it, the bones can break off. You can have loose bodies in the joint. And altogether, this just leads to pain, inflammation, resulting in stiffness in the joints. What are the risk factors? Well, for osteoarthritis, the main risk factor is age. Again, it's an age related finding. Also being overweight, that can lead to increased pressure, increased stress on the joints. If you have any kind of previous joint injuries from sports, it could be an ACL tear, a torn meniscus, or a hip injury when you were younger. Another risk factor is muscle weakness. Strong muscles help offload pressure in the joints. And unfortunately, there's also a genetic component to it. So if you got a strong family history, you're more likely to have it. So what are the warning signs? Well, I mean, it's pretty straightforward. You're gonna have pain, stiffness, or swelling in either one or multiple joints. It basically leads to difficulties moving. So what are the treatment options? Well, we always like to begin conservative. And the main thing when we first start with treatment for osteoarthritis is changing habits and exercise and activities. You may have to limit some activities. One of the main things is pacing of your activities. So instead of going all out 100% until you can't go anymore, we recommend taking regular breaks. If you're on a long car ride or doing a lot of repetitive motions, maybe changing positions, and then just slowly increasing the amount of work you're doing gradually. Don't go all out at first. Other things we can do for activity modifications are joint protections. Could be like in the form of a brace or a cane or a walker for walking, or even just something to pick something off the ground so you're not having to bend over, like a grabber. Again, exercise and physical activity are actually good for arthritis. It can help limit some of the inflammation and maintain that motion. Using heat and cold, one to help, what I usually recommend is heat when you're warming up and to get started, and cold at the end to help kind of limit the pain and the inflammation. And then proper nutrition, maintaining a healthy diet. There are some medications available, and then obviously kind of the end stage arthritis when you get there, the last step is surgery. So what kind of exercise are we looking for with people with osteoarthritis? The main things we're looking for are low impact exercises, really focusing on range of motion, strengthening and endurance. Again, we like to use a lot of hot and cold therapy. I usually recommend for my patients, hot therapy for when you're warming up to help loosen the muscles up before you get started with exercise. This can be in the form of hot packs or heating pads or even hot tubs or warm showers. And then at the end of exercise, or the end of the day, when the inflammation is at its worst, I recommend cold packs. This, again, can be in the form of ice packs or cold packs, or even just a bag of frozen vegetables out of your freezer. Any of these will work. So what are the medications? Again, we'll try to start with the over-the-counter medications, the Advils, ibuprofen, Motrin, naproxen. There are some prescription medications like Mobic or Celebrex. These are usually a little easier because they're maybe taken once a day and they can be a little easier on the stomach. The main contraindications of these are stomach ulcers, people that have, or people that are on blood thinners for other issues. A lot of times if you're on Coumadin or other kind of blood thinners, these non-steroidals are going to be contraindicated. Just a list here and some pictures of some of the ambulation or assistive devices. You know, it can be a cane or a walker, or even if needed, a wheelchair. And then, you know, if all of our non-operative options fail, you know, kind of the last stage is joint replacement. Got a couple images here. The image on your left is a unicompartmental knee replacement. So somebody who had just arthritis on one part of the knee, so they're able to do just replace that one part. These can be done fairly quickly and done as an outpatient. Actually, most of all of our joint replacements now can be done as an outpatient. On your right, you see an X-ray of a total knee replacement that was done there. And then on the right bottom, there's an X-ray of a total hip replacement. Again, most of these can all be done on an outpatient basis now. So what are the key points to remember with arthritis? Understand, one, there's really no cure, or for osteoarthritis. One, there's really no cure for osteoarthritis, but we can manage the pain and the discomfort. This can involve a multitude of treatment modalities, from activity modifications to medications, and then end stage, if we get to it, could require joint replacement. The key thing is don't give up. You know, continue to work, find the things that work for you. One thing that works for your neighbor may not be the best thing that works for you. So trying different things to really get to what gives you the best effort and gives you the best ability to continue to do what you want to do. So we're going to roll this into osteoporosis. This is a disease. This is actually a disease of the bone. It affects the bones of the entire skeleton. All right. Basically, osteoporosis causes bones to lose density, which leads to them becoming weak, and can lead to higher incidence of fractures. One thing to understand about osteoporosis, it is preventable and it is treatable. Okay. This is a very costly and deadly disease that we see. As orthopedic surgeons, we're kind of trying to get to the forefront of this. This has been, I would say, it's been undertreated in the past, and over the last probably 10 years, this is really coming to the forefront of medicine and orthopedics. You may see your primary care is now starting to focus on this, but the thing with this is, you know, once you have one fracture related to osteoporosis, your mortality and morbidity goes up extensively. So cost of your medical care as well as your just your overall quality of life. So we're really trying to get this earlier and prevent these injuries from happening. At Ortho Georgia, we have started a bone clinic that basically just deals with osteoporosis. We have somebody there 5 days a week. So what are the risk factors for osteoporosis? The number one, or one of the main risk factors is more common in females, right? 61% of all osteoporotic fractures are females. If you have a family history of osteoporosis, white race is an increased risk. And basically anybody over the age of 65 with these risk factors has a higher risk. Some of the modifiable risk factors, actually having too low of a body weight is a problem. Less than 85% of your ideal body weight can lead to increased risk of osteoporosis. Having an increased weight actually puts a little bit of increased stress on the bones, and bones like to remodel and grow under stress. So if you can maintain an ideal body weight, you can keep that stress, the normal stress on the bones, and they'll continue to remodel and stay healthy. Another, again, that goes right along with the limited exercise. If you're not exercising, maintaining a healthy weight, or maintaining, you know, that stress on the bones, they will not turn over and remodel with healthy bone. History of broken bones of the past. There are certain medications that do cause increased bone turnover. Long-term steroids like glucocorticoids. There's some anticonvulsants for seizure medications and other medications that can increase your risk of osteoporosis. Heavy alcohol intake, also having an estrogen deficiency, if you have low calcium or vitamin D intake, as well as smoking. So what are the most common fractures we see? Most common fractures across the board are going to be hip fractures, as you can see here on the image on the left. Also having a wrist fracture or a distal radius fracture. And the absolute most common fracture we see, and that I see a good bit in my practice, is a vertebral compression fracture of this image on the right. This is just another drawing of a vertebral compression fracture. You can see on the left, a normal vertebra, kind of a square there. And then when bones become osteoporotic or weak, even under non-traumatic incidents, just some people just rolling over in bed or just standing up or even maybe just bending over can end up having these compression fractures. And the way I kind of tell them, it's kind of like crushing the vertebra, the vertebral body like a Coke can. So, like I said earlier, these vertebral compression fractures, or VCFs, are the most common fractures seen in osteoporosis. Roughly 700,000 of these fractures annually, nearly one every 45 seconds. And 1 in 3 women and 1 in 3 men over the age of 50 will experience an osteoporotic fracture, most likely a vertebral compression fracture. The biggest thing to understand with this is that once you have one, the risk of subsequent increases significantly, up to about a 5-fold increase. And so the main thing is, when I see these in clinic, the first thing we're going to do is obviously we're going to treat the pain and treat the symptoms for that. But I'm going to get these people into our bone clinic, or get them to their primary care or somebody to start treating them, because once I see a vertebral compression fracture, the diagnosis is already made. We know you have osteoporosis. Now we just need to start treating it. So what is the medical management of a vertebral compression fracture? One, sometimes we will put them on bed rest when they're acute and they're in severe pain. We can do narcotic analgesics. We really try to limit these. We can also do bracing or just oral anti-inflammatories. Some of the shortcomings of these are that they, obviously they may fail to relieve the pain. Not everybody gets relief with just the non-operative managements. It doesn't really provide any kind of long-term functional improvement. When they have these vertebral compression fractures, these are the ones you start seeing when they get further and further bent over when they have subsequent fractures. And then that leads to less mobility and leads to exacerbation of their bone loss. So this is an example of a kyphoplasty, which is one of the surgical treatments we have for these vertebral compression fractures. It's a minimally invasive procedure. It's actually 2 very small incisions where we, on the side of the back, and we insert this trocar that you can see kind of going in. And then if we put a balloon in there and kind of expand the vertebral body and expand the space in there, and then we can fill it with cement. And this will help solidify it and stabilize that, and hopefully recreate some of the normal height that you had prior to the fracture. This is just kind of a post-operative x-ray. You can see the cement in the vertebral body there. So how do we screen for osteoporosis? The main way to screen is a DEXA scan, or bone density scan. This can help predict your bone strength. It's what we use to diagnose this. I don't know if anybody's ever had a DEXA scan, but when you go in, they do give you a lot of numbers. You get a T-score and you get a Z-score, and they may give you something called a FRAX score. A lot of numbers, but basically what it comes down to is we're looking at the end is going to be your T-score and your FRAX score. And your FRAX score is basically the percentage or the incidence or your risk of having an osteoporotic fracture. And I think once the number gets to a certain point on that FRAX score, that's when you're going to start treating it with medications. So again, the most important thing for osteoporosis is prevention. All right. That's with adequate nutrition, having a good caloric intake, maintaining a normal calcium and vitamin D level. These are just some of the recommendations as we get older, starting with adolescents up to postmenopausal women and men over 65. And the other thing is exercise, staying active. You need to keep the pressure and the stress on your bones so that they can remodel in a normal pattern. All right, now we're going to get into a little bit of what I specialize in, spine surgery, or people coming to see me on a daily basis for lower back pain. Okay. Now, acute low back pain is one of the most common presenting complaints to primary care physicians. Depending on where you look, it's also the most common presentation to the emergency rooms. Roughly 80% of the population at some point in their life will develop low back pain. Good part about this is that 75% of these will get better on their own, usually within 4 to 6 weeks. If you're under the age of 45, this is probably the second most common reason to miss work. And as you can see, it's a significant cost in healthcare to our society. So what are the most common causes of low back pain? Well, Far and away, the most common causes are a lumbar strain or sprain, or degenerative joint disease, or that osteoarthritis that we talked about earlier. We're looking at lumbar strains. Again, this is very prevalent, the most common cause people that come to see me in office for low back pain. The etiology of this is fairly controversial. Is it more muscle related or tendon related or ligament? Could it be due to the underlying joint arthritis or disc abnormalities? This is mostly the people that come in to see me that have pain kind of on the sides of their back, may kind of wrap around in a band, but doesn't really go down their legs and kind of like a sciatic distribution. Again, the majority of these will resolve on their own, which is the best part about this. Second most common cause is lumbar degenerative disease. Again, this goes along with that degenerative arthritis we talked about earlier. This is age-related degenerative changes that can be in the disc or in the joints within the back. And understand that at each spinal segment, there are 3 joints. So in just the lumbar spine, there are 15 total joints alone that can become arthritic. Another common cause of back pain is a herniated disc. As you can see in this MRI here, you can see where the disc is not contained. Again, the vertebral body is herniating out into the vertebral or the spinal canal. This causes pain in a very predictable pattern. This is the ones where people come and say their sciatica is acting up, or they're getting that severe pain, that kind of pins and needles or electric pain going down the back of their leg. Generally, that's used to either going to be due to a herniated disc or spinal stenosis, which we'll get into in just a second. We've already talked about compression fracture, but also a very common cause of back pain. Next cause will be spinal stenosis. Again, this is usually related to age-related changes. As we get older and our discs collapse, they kind of bulge out like a water balloon. You get overgrowth of the facet joints, or the joints in the back, from the arthritic changes, and so all that causes encroachment of the spinal canal, which can lead to pain in the back, as well as, again, kind of the sciatic type symptoms. Another common cause that I see people coming in for back pain is what we call a spondylolisthesis, which basically means an instability or a sliding forward of one vertebral body over another. These can be from trauma, from a car wreck, or from an injury doing sports, or they can also be due to degenerative changes, okay? If they're traumatic, they're usually gonna be at the lower level at the L5S1. If they're from a degenerative changes, so those joints in the back become arthritic, they become overgrown, they become a little unstable, and causes them to start, the level above to start sliding forward, that's generally gonna be at the L4-5 level, okay? Understand when this happens, there's a tube that goes right down the back. And if you're sliding part of that tube forward and holding one part still, you're gonna be pinching that canal again. So again, not only will this cause the back pain, but it can also cause that sciatic type pain that we see. The next one we see is spondylolysis. Now this is usually more common in adolescents, like they're hyperextension athletes, our gymnasts, our football linemen, our weightlifters. We're starting to see it in a lot of lacrosse players where they're really leaning back, putting a lot of pressure on those lower lumbar vertebrae. And basically what it is, it's just an overload injury of the lumbar spine. Their bones aren't really strong enough to handle that stress, and they come and they see me and they say, look, I've had back pain. This has been getting progressively worse, as with sports over the last several weeks or even months. Sometimes they go months before they see us. The good thing is that we catch it early enough when it's just some of that stress reaction, and before it's a fracture, we can treat these by just limiting their activities. If it does become a fracture, we can still, there's other things we can do, but sometimes these do require a surgical intervention. So what are the goals of spine care? What are the goals when somebody comes to see me? Well, obviously the main thing is they're coming to see me because they're hurt. So we want to relieve their symptoms. We want to help get their pain better, okay? The next thing is restore or improve their function, okay? You're coming in with leg pain, or you're coming in with a deformity, you're going to be limited in activities that you can do. And then the final thing is prevent this from happening again, okay? Main symptoms we're treating, again, is going to be pain. This can be axial or paraspinal, so pain localized just to the back, or that nerve pain that we're talking about in that sciatic distribution. Also, we're treating the abnormalities of neurologic function. Some people come in with pretty significant weakness. You see some people walking around with a drop foot or having a limp because they have weakness in their leg. This is usually due to the nerves being pinched in their back. And then for deformity, I know I talked I forgot your name, talked to him earlier, having a big deformity surgery next week. That's one of the main things is fixing deformity. So the first line of treatment, if you're not having any significant weakness, is always going to be non-operative management. This can be done through a multitude of things, from drug therapy, over-the-counter NSAIDs, prescription medications. We can use some bracing. There's some indications for some traction and spinal manipulation that we can get you into our physical therapist to do. Working with our physical therapist, doing the hot cold therapy, ultrasound, massage, the TENS devices. I know a lot of people probably have those at their house. The TENS devices are really good for that paraspinal kind of lumbar strain. Other things we can do are epidural steroid shots, which are basically a steroid shot that go directly in your back along the nerves to help relieve that kind of sciatic pain that you're having. We can do that at our office, or we can even get you into a pain clinic that can do those as well. These are just some examples of some of the conservative exercises that we have, the therapy, the stretching. This is a picture of the epidural steroid shots. We really have roughly 2 locations where we can put these in at each level. One could be an interlaminar where we would kind of go in right in the middle of the back. And the other one's a transforaminal where we're coming off to the side, which you may hear is commonly called like a nerve root shot. So all non-operative interventions fail. And now we start talking about a surgery. So what are the goals when somebody comes to see me and we failed all of our non-operative interventions and we start talking about surgery? Well, the first goal is always to decompress the neural elements. Make room in their spinal cord for their nerves. Get rid of their sciatic pain. Get rid of their risk for if they were in a cervical, if they had a risk for a spinal cord injury. We've got to take care of that first, okay? Then we got to look at stability. Do we need to stabilize the spine? Do they have an unstable, do they have a slip? Do they have a big deformity? Do we need to do a fusion or not, okay? And those are really kind of what we're going to go down to everybody that comes to see me when we start talking about options we have for surgery. The good thing is we have many new minimally invasive techniques. If you come to see me and you have just a herniated disc with sciatic type pain, but no real back pain and no instability, we can do a minimally invasive discectomy. This is an outpatient procedure. It takes roughly 45 minutes. You have maybe an incision about an inch or so in your back. Or maybe you come to see me and you have a radiculopathy or kind of the sciatic symptoms, but in the arm. We can do disc replacements now instead of fusions. And when it does come to fusion, we have minimally invasive fusions where we use the robot. This is a picture using robotic guidance here to place screws in the lumbar spine. This is just a kind of a drawing of what it is during a discectomy. You can see on that far left, that red spot there is a piece of disc that is coming out and it's herniating and hitting that nerve root in the canal or the tube there. We're able to make a small incision and go in using small retractors and a microscope and just remove that one piece of disc. We don't go after the rest of the disc, just that one piece that's herniated out to get the pressure off of that nerve and allow to have pain relief from that. This is an example of a disc replacement done in the neck. So somebody comes in with a bad disc in the neck, causing pinching of the nerves in their neck, leading to arm pain and shoulder pain. As long as they don't have any instability or significant arthritis in their joints, we're able to do a disc replacement to help maintain motion. Again, these can be done on an outpatient basis on a procedure that takes roughly an hour to an hour and a half. And this is a minimally invasive anterior lumbar interbody fusion, or ALIF. What you can see at that bottom level on the left, there's a spondylolisthesis, again, where the one vertebral body on top is sliding forward. And this is due to a spondylolysis, or a fracture in that bone in the back. It's hard to see on that x-ray. But what we're able to do now with our new minimally invasive techniques is actually go through the front and through the abdomen and get a better reduction or alignment of this slip. We put the titanium spacer in there to hold it and to maintain the disc or maintain the height so it doesn't collapse back down. And then we're able to use the robot to put the screws in through 2 small incisions in the back. This allows us to do these surgeries with less blood loss, faster recovery, because we're not having to strip any of the muscles in the back. People generally stay in the hospital one night and go home the next day. There are people doing these as an outpatient, but we're not doing these locally as an outpatient right now. I just kind of follow this up with this here, just saying that the choice of a particular treatment should always be based on evidence-based medicine. There are some procedures out there. You'll see some advertising, most notably laser treatment. Understand there's really no data backing that up. They've done a very good job advertising. I get asked that every day about that. But understand that the actual people that started that, I think it's the Laser Treatment Center down in Tampa, has closed down. because they didn't actually provide any real relief of patients' pain. This is just a little bit of information on Ortho Georgia in general. We have 24 orthopedic surgeons in all subspecialties of orthopedics. This is just a list of all of our surgeons. We have offices, 6 different offices, one here in Milledgeville, just down the road. We have 2 urgent care centers in Macon and Warner Robins. We have 2 surgery centers, and we can do all of our diagnostic imaging in-house. Thank you. I think we have a few minutes for any questions. Can be questions over just general orthopedics or spine or anything? Go ahead.
How often do you see spinal tumors inside the dura?
Intradural spinal tumors are pretty rare. Just a very few a year.
What causes it? I have.
They can be, there's multiple different causes, ependymomas, meningiomas. There's a whole list of them. There's genetic components to it. Otherwise, you know, it's just kind of bad luck, really. I mean, there's no real direct cause.
Do they tend to recur?
Depends on which kind it is. Some of them don't, some of them do. A lot of them, like your benign, like a schwannoma or a ependymoma, some of them don't even have to be resected, depending on if they're causing pain. The ones that you are resected generally don't recur, though. Yes.
Thank you so much for your presentation. I just wanted to know procedurally how a person comes to.
It really, so a lot of times it's going to be from their primary care physician, from a referral. You can also, depending on your insurance, you can just make a call in and make an appointment on your own. Some insurance companies do require primary care referrals, but I think that's really kind of going away. I think for the most part, there's only like 1 or 2 that require that anymore. So if you're having any of these symptoms, you can just call our office and they can get you in either here or wherever you need to be seen.
How do you treat chronic gout?
Chronic gout, that's a tough one. There are some medications. There's because it's basically related to the uracil, I think. And so there's medication like colchicine, indomethacin for like acute treatments, and there's some other newer medications. We typically refer to the treatment for those to like a rheumatologist, but there are some new medications that help lower those that acid that causes the gout. Unfortunately, it's a tough one. I think one of the main things is really diet.
How common for like especially tech workers a lot of times maybe not seems like there's a lot of tech problems.
Yeah, because I think you're putting an abnormal stress on the muscles in the neck from the leaning forward, and really just because they're not getting up and moving. And so I think a lot of people notice a huge difference at the stand-up desk, and they're able to get the screens up to eye level. That makes a huge difference. So even if you're sitting down, if you can get a higher screen at eye level, so you're not having to lean over like that and stress those muscles, that makes a big difference. But typically, and I do see a lot coming to clinic, a lot of those people just get better with just physical therapy.
Are there any exercises?
Yeah, the main thing is just maintaining the paraspinal strength and range of motion. And we have a list of them. I have a little handout that we give them in clinic. Any other questions? All right. Well, thank you again for having me today. I appreciate it.
And, Greg looked at that and makes it anything about material. And then this book will go over in our Jill book collection at the library. So he will just again. All right. And if we don't have any other announcements, then everybody go out and have a wonderful week, and we'll see y'all. I'll see you in 3 weeks. So Joe is going to fill in for me next week because I'll be in Franklin, Tennessee, and then Karen is going to fill in the following week. Well, I'm in Maine on vacation. So I'll see everybody back in 3 weeks. Have a great day.
Website.
Okay. Yeah, let's go do it.
Yeah, you want to do it here? You want to do it there?